Okay, good evening, everybody. My name is Dr. Jered Weinstock, and I am a board-certified pediatrician and almost a full-fledged pediatric pulmonologist within the next 3 weeks, coming to you live here from Washington, D.C., the capital of the United States of America, here on the East Coast. I really am honored to be here tonight. I really want to thank MDForLives for sponsoring my presentation tonight and inviting me to give this talk to all of you here on bronchopulmonary dysplasia. So just a little bit more background on me. I am currently employed at Children's National Hospital in Washington, D.C. And as you can imagine, we see a wide range of pathology on a daily basis, even within our pulmonary division at the hospital. In fact, our NICU, our neonatal ICU, is the #1 NICU in the entire country here. And we spend a lot of time in this NICU treating our patients. And in fact, we developed, as part of our pulmonary division over the past few years, a complex bronchopulmonary dysplasia program, whereby we collaborate with our colleagues in cardiology and NICU to help effectively treat these patients. So my interests over the last few years have included prematurity and also respiratory epithelium. And I've been very grateful to be part of a lot of research, both clinical and translational, at Children's National Hospital. And I really would like to give a shout out to my research team there for such a great job and allowing me to be part of such fantastic work. So I'm really excited for this webinar tonight on bronchopulmonary dysplasia, and we are going to begin. So I will share my screen. The way it will work is that I will talk for approximately 30 minutes or so, and then I will open up the floor to a question and answer session. While I am talking, please feel free in the Q&A part at the bottom of your screen there to write any questions, and at some point during the presentation, during the Q&A session, I will address those questions completely. So let's begin. Let me share my screen here, and we will get started. And again, thank you all for joining. Let me just move my screen here and put it in present mode. Okay, perfect. I hope you can all see the screen. So tonight, the webinar's title is Bronchopulmonary Dysplasia, the Past, Present, and a Promising Future. I do not have any disclosures, but we do have a slide here just to show that all views or opinions are expressed by myself, and MDForLives does not endorse or confirm the views of what I am saying tonight, nor does MDForLives make any warranty, express or implied, and disclaims any liability or responsibility for the accuracy and completeness of any opinion and views expressed by myself. So here are the goals and objectives for tonight. So why bronchopulmonary dysplasia? Well, like I said, I do have an interest in prematurity, and the field of prematurity and neonates in general who are afflicted with bronchopulmonary dysplasia is really an area that has come a long way and still has a lot of work that it continues to be done that looks very, very promising. So tonight we'll discuss a little bit of the past, including some various definitions of bronchopulmonary dysplasia, or BPD, as I will refer to it from here on out. We will determine whether BPD exists or not, how we exactly determine that. And then in terms of current practices, we will review the advances that, like I said, have come a long way in neonatal care. And these include surfactant administration and even the development of some alternative strategies for surfactant that we will talk about, in addition to a whole other variety of different strategies that we employ nationwide in terms of ventilation, primarily focusing on both non-invasive and also mechanical ventilation as well. We will discuss some of those strategies, and then also, most importantly, discuss the future of BPD and where we are going most likely in the forthcoming years. So if someone were to ask me to define bronchopulmonary dysplasia in a simple manner, a one-liner basically, I would really call it a form of chronic lung disease that primarily develops in preterm infants, but also those who are or those who are treated with oxygen and some form of positive pressure ventilation. Now, the definition of BPD is an ongoing debate, and the actual concept of it was first coined over 50 years ago by this group that you see on the screen here, back in 1967, Dr. Northway and his colleagues. Dr. Northway was a radiologist who, in observing this lung disease in preterm infants, really found this pattern of hyaline membrane disease, now known as respiratory distress syndrome, or RDS. And back in that time period, BPD was a highly lethal condition. Most infants did not even survive, below 34 weeks age gestation. It was a very dismal prognosis. And this was primarily the result of mechanical ventilation without PEEP, and also the high levels of supplemental oxygen that these infants were exposed to early on, with really no other strategies available to really effectively treat them. So as you can imagine, over the last 4 decades, the original definition has really been extensively modified. And the one that we mostly use in general, which again has had some adjustments as well over the years, is one that nearly 20 years ago was developed by a group of colleagues in the United States here. And what we say, or what we use anyway in general, is we look at an infant who was born premature, who has been on oxygen therapy of greater than 21% for at least 28 days. At the 36 post-menstrual age mark, 36-week post-menstrual age mark, we then look at these infants and determine whether they have mild BPD, moderate BPD, or severe BPD. And that's really based on the amount of oxygen or type of ventilatory support they are requiring at that time period. So this has really been the popular way of categorizing BPD and defining it over the past few years. But again, over these last even few years recently, the definition and the definition debate anyways has continued to evolve to the point that the definition that I just mentioned on the previous slide has even been modified even further to create different grades of even severe BPD, so that we as clinicians have an idea of maybe what exactly the prognosis of these infants with BPD is moving forward. You can see here sort of a redefined definition of what I just mentioned on the previous slide by a group led by Walsh and colleagues, looking at infants, again, trying to define BPD between 35 and 37 weeks post-menstrual age, and really using the following criteria: whether these patients were requiring mechanical ventilation, continuous positive airway pressure, or CPAP, or supplemental oxygen of at least 30%. If these patients had oxygen saturations between 90 and 96%, they did not require any additional testing. If these patients did seem to require intermittent oxygen, and there was maybe a chance that they could be weaned off, this group came up with a stepwise reduction to room air. And if these patients failed that stepwise reduction to room air, then of course they were diagnosed with BPD. So you can see, by really redefining BPD and adding these more specific prognostic markers, you can imagine that the overall rate of BPD over the years has actually been reduced, because some of the patients who previously fell into the category of being diagnosed with BPD no longer fall into that category based on some of the different definitions that are out there. So again, there's been extensive modifications over the years for the definitions that we have. And it really is, like I have said, an ongoing debate that is still being worked upon to come up with that ideal definition. And this all really falls into play here when we look at the complex pathogenesis of BPD. It's not simple. You can see here on the screen here, and we will go through it briefly, really all the different factors that come into play in looking at the development of BPD itself. So even looking at the intrauterine lung development, it's so important. And we're going to touch upon that in a little bit. But you can see even in utero, in these infants, if they are exposed to a significant amount of stress, whether that be growth restriction or any kind of infection, pro-inflammatory cascades, etc., these things can have a significant impact on the lung development, even in utero, before these infants are born. Now, fortunately, probably in the early to mid 90s, the advent of antenatal glucocorticoids, or at least the use of them, became very popular and still remains a very popular, or still plays a very popular role in treating moms with babies that are presumed to be premature, to really help boost their lung function and boost that surfactant production and help to decrease the fetal lung fluid in utero, so that hopefully, if these patients go on to have bronchopulmonary dysplasia, it's really not as severe as it could be without the use of these glucocorticoids. Now, they haven't been found to really reduce the rate of BPD, but again, the mortality has really been improved with the use of antenatal corticoids. Now, the postnatal lung development, again, after these babies are born, a lot of different factors come into play in how this progression of BPD continues. So you can see most of the babies with BPD require, especially those with severe BPD, which we'll talk about, require some form of ventilation or oxygen support, especially as they start to get a little bit older. By the time they're at least 2 to 4 weeks, that ventilatory support tends to worsen over time if these patients have a severe form of the disease. And you can see here that these bottom 3 factors all come into play and affect the introduction of an inflammatory state in these patients. Things like exposing these patients to a hyperoxic state. We know that high amounts of oxygen lead to the creation of free radicals, and this has a detrimental effect on the cell membrane and on mitochondrial function, for instance, and in general can lead to an increased inflammatory state. In addition, by treating these patients with the ventilatory strategies we have, even though we're trying our best to minimize the amount that they're exposed to, these patients tend to have an overdistension of their airways, which obviously in terms of volutrauma and barotrauma can create factors leading to an inflammatory state and affecting their lung development long term. Now, we'll talk about when we get to management, the use of glucocorticoids. Again, it's been a hotly debated topic, but we have seen with some studies some positive benefits in using these to treat patients, especially with severe BPD. And nutrition is a huge thing for these babies. These babies, the earlier they are started and maximized on proper nutrition, the better their lung growth is. And even in the outpatient setting, when we follow these patients with BPD, we are very focused on their nutritional status, because weight gain is very important. If we have an infant who is not gaining weight, we get very concerned for their lung growth. So somebody who's optimized with nutrition tends to have better outcomes long term. So you can see all these factors contribute, unfortunately, to lung injury and the inhibition of lung development as time goes on, but you can clearly see that the pathogenesis itself is very complex. Now, there are many risk factors here. So prematurity and low birth weight, we know, have an inverse relationship with BPD. So let's say, the lower gestational age, for instance, at 22 to 24 week gestational age, has a higher incidence. You can see here, those born in that age range usually have an 80% incidence of being diagnosed with BPD, whereas those born at 28 weeks gestational age, which again is still considered extremely premature, only about 20% of them are found usually to go on with bronchopulmonary dysplasia. And again, like I said, low birth weight is also a huge risk factor. 95% of the patients with BPD are of the very low birth weight category, or those patients born below 1,500 grams. You can see here on the right some other risk factors that we also consider in the development of BPD, including IUGR or intrauterine growth restriction, male sex, and there's a hotly debated hot debate going on here about chorioamnionitis. It's been going on even most recently here in terms of its inflammatory state that it really activates in utero, and it's been shown that a lot of these pro-inflammatory cytokines develop as a result of chorioamnionitis and may go on to invoke BPD long-term. Smoking, again, is something we take into consideration. And then long-term genetic risk factors. There are many ongoing studies looking for some genetic markers of BPD. So I want to pull up a poll here because, we are going to talk about lung development here, but let's see, going back to embryology for those of you who have had the training. If not, just take a wild guess here. The question is, what stage of lung formation is occurring around 24 weeks gestation? So we'll try to make this a little interactive here. I'll give you a few seconds to pick a choice. Please don't worry about getting the answer wrong. This is a very difficult area to remember. So majority here pick saccular, close. At 24 weeks gestation, we're usually in the canalicular phase of lung development here. So let me share the results. So you can see here, majority picked saccular. However, canalicular is the correct answer. And we're going to talk about that right now. So like I said, lung development is very important to take into consideration here when we talk about BPD. With normal lung development, so somebody who's not born premature has developed, their lungs as we would expect to for full-term infant. We remember that there's a close interface between those alveolar epithelial cells and the pulmonary microvasculature, or the endothelial cells, which help to provide for an efficient exchange of oxygen and carbon dioxide. And remember, this is a normal lung development. Now, when do the lungs start to form in utero? Believe it or not, very early on, between week 3 and 6 of gestation. I usually tend to think more towards week 6, but again, very, very early on, we're in that embryonic stage of lung development. And there are many, many complex interactions that go on that involve different types of cells here that you can see listed, various mesenchymal cells, respiratory epithelial cells, and endothelial progenitor cells that help to really form a normal lung. So imagine we have somebody, and we'll see on the next slide in picture form, a baby born at that 23, 24 week mark. Again, the alveolar stage of lung development doesn't even occur until that last trimester, around 36 weeks gestational age. So if we are cutting off that normal lung development when these babies are born earlier, we can certainly expect many issues to occur as a result of that early or cut off development of their lungs here. So you can see in that last trimester, especially around 36 weeks gestational age, the number of alveoli certainly increases, which provides for that nice surface area for gas exchange. And then also, as we get closer to the end of that last trimester, the peripheral lung epithelial cells also mature, meaning our alveolar type 1 cells and alveolar type 2 cells. The alveolar type 1 cells are very important in terms of increasing that surface area of the alveolus itself to provide for nice gas exchange, whereby the alveolar type 2 cells are the ones known to produce pulmonary surfactant, which is very important in decreasing that surface tension for these babies early on in life. So again, those preterm infants born around that 22, 23 week mark, remember, they're starting to do their own ventilation in the canalicular saccular stage, right at the cusp there, especially if we're talking about even the 27 to 28 weekers who are right about at the saccular stage. They haven't really even formed any alveoli yet. So we are cutting off essentially their lung development early on, well before morphogenesis and that alveolar differentiation have been completed. So in picture form here, this comes from a Nature journal, a very nice review of BPD here. But just to put the lung development in picture form, you can see that again, early on, we start with that embryonic stage and we progress basically every 10 weeks or so to the alveolar stage, which occurs right around that 36 gestational age week mark. And again, you can see here, you don't even have the development of these specialized alveolar type 1 and type 2 cells really until the later parts of embryonic development. So this is just to drive home that point that really early on, these extremely premature infants are really going to have major issues in terms of gas exchange with as a result of the early lung development. So before I go to that, let's pull up the second poll because that'll give us the answer on the next one. So the second poll here is on pulmonary surfactant, and let's see, again, no stress here in anything, but just give it a guess here. Which pair of surfactant proteins primarily assist in reducing surface tension? The hint here is that they come in pairs. Okay, so just to share the results, we had a tie here. So the correct answer is number 2, surfactant proteins B and C. The best way to remember this is that A and B are actually supporting airway defense. So those are the proteins really helping with the immune part of the lung. So AD, airway defense, whereby B and C are the ones primarily known to be producing that surfactant. And in fact, as an aside, we see patients with different forms of interstitial lung diseases in those infants that maybe have a deficiency in surfactant protein B or C. So again, pulmonary surfactant, very, very important. It's a complex mixture of phospholipids, primarily phosphatidylcholine, and those surfactant proteins that we just talked about. And it really depends on that differentiation of the alveolar type 2 cells, which produce these 4 different types of proteins. We already mentioned it occurs fairly late in gestation. So you have somebody born around 23 to 24 weeks, they're most likely not going to have that nice surfactant production that we see later on. So the lack of this will lead to that respiratory distress syndrome that we usually see as a presenting picture, clinical picture anyways, in our BPD patients. So we see here that postnatally, the adaptation of the preterm lung to breathing faces many challenges. We just talked about surfactant deficiency. These patients are then exposed to increased oxygen as a result of that poor gas exchange that's occurring in the alveoli and in the lungs. And then, unfortunately, some of these patients require mechanical ventilation, which then goes on to provoke its own problems. And if we have patients with inadequate nutrition and some type of infection or inflammation, these are major challenges that the preterm infant faces. Now, I just want to show here, again in picture form, because it's nice to see for those of you who enjoy visual aid here, the alveolus and how it looks. So we talked about the different proteins that help to make surfactant. Remember, B and C are the primary ones. A and D, remember, airway defense. They help with the immune system aspect of the lung itself. And you can see here that this is an ongoing process inside the alveolus, which there are many, many, many in a fully developed lung here. And then along the sides here of the alveolus, you can see these thin squamous cells known as the alveolar type 1, which again help for that nice gas exchange here with the vasculature. You can see the endothelial cells, which help with the gas exchange of oxygen and carbon dioxide. So very important to understand here for those of you who may be treating BPD or premature infants or even dealing with them in the outpatient setting, that the fact that, very early on, they lack that nice surfactant production. Now, I want to spend a minute here just talking about some of the different therapies or strategies that have been out there most recently in terms of surfactant administration. Remember, surfactant administration for these patients is very, very important early on because they are not producing it themselves. So, prior to some of these newer strategies, we usually have to intubate these patients and instill the surfactant intratracheally, maybe 1 or 2 times, after birth. And we watch these patients on a mechanical ventilation, and as expected, usually the surfactant will help to decrease that surface tension and increase the pulmonary compliance of their lungs to really help them effectively ventilate better. Now, the only issue with this is that over the years, we've seen that even that intubation, just intubating them for surfactant administration, has caused some damage with their airway, and we really long-term would like to avoid having to intubate these patients. So some of the alternative strategies that are now out there include some of the abbreviated or acronyms that they're using, LISA, or less invasive surfactant administration, or missed minimally invasive surfactant therapy, meaning instead of intubating these patients, we're using a fine catheter at certain institutions to really instill the surfactant that we have available into these patients rather than intubating them and causing damage. And there have been many studies looking at these alternative strategies, and they appear to be very, very promising long-term. So we hope in the near future, some institutions, there's more institutions anyway, will start to adopt these alternative strategies for surfactant administration. So the management of these patients, again, usually the clinical presentation involves respiratory distress syndrome. So surfactant replacement, very important. We really would like and tend to use continuous positive airway pressure early on. If these patients are able to tolerate that before any type of invasive mechanical ventilation, this is ideal, again, to help prevent any kind of airway damage long-term and to hopefully minimize the severity of the BPD that these patients may go on to develop. And of course, barotrauma and volutrauma are always concerns given the high volumes and high pressures that these patients may require early on. So the treatment, unfortunately, to help recruit these alveoli and prevent atelectasis or collapse of the lung, unfortunately leads to lung injury and this inflammatory cascade activation that we really tend or have to keep an eye on as we treat these patients effectively. We talked about nutrition and the very importance of that long-term for these patients in helping to develop their lungs. And then I would be remiss to not mention pulmonary hypertension. Remember, early on, these patients have a great deal of angiogenesis going on. They're developing their pulmonary microvasculature at the same time that their lungs are also developing in utero. So if this whole process is disrupted, these patients tend to go on to develop a high degree of pulmonary resistance. And unfortunately, especially in our severe BPD patients, tend to develop pulmonary hypertension, which is why at our institution with our complex BPD program, we have our partners in cardiology on our team to help us evaluate our patients in a team-wise effort there so that we can really help treat these patients as much as we can, because the earlier this pulmonary hypertension is treated, the better the outcomes are moving forward. So before I get to the ventilatory strategies, poll number 3, very quickly here. So the question, when treating bronchopulmonary dysplasia, which of the following are optimal targets? So again, you're looking at different pH levels, the carbon dioxide levels here, and oxygen saturations. So there's 3 choices. So again, I'm not making it hopefully too complicated, but just imagine this is a BPD patient and pick your target here from the following choices, please. Okay, so let's share the results here. So we have a winner. Number 1 is the answer. So we'll talk about this, but in our BPD patients, we tend to permit permissive hypercapnia, okay? So although, yes, a normal CO2 or carbon dioxide is really 40 to 45, we tend to allow these patients to have a higher PCO2 level just because it really does help long-term with weaning mechanical ventilation. And many studies have shown that the benefits of this permissive hypercapnia actually outweigh the risks. So yes, choice A is the winner here. Again, because the PCO2 is a little elevated, we'll have a little decrease in that pH. And in terms of our oxygen saturation, sure, it's on the low side, but remember, we do not want to expose these patients to significant hyperoxic levels because remember, oxygen is a drug and promoting free radicals is certainly not going to help these patients, especially those who have severe disease. So good job with that question. So in terms of ventilatory strategies, spend a few minutes talking here about 2 different types that we use. So this first slide here talks about the prevention of BPD and the ventilator strategy that should be employed in order to help prevent disease. So you can see here, low tidal volumes. We really don't want to cause volutrauma and inflict even more damage on their lungs. So we tend to use about 3 to 5 ml per kg of body weight in terms of their tidal volume. Short inspiratory times between about 0.2 to 0.3 seconds are recognized as optimal to prevent BPD. And yes, we need to increase that PEEP, the positive end expiratory pressure, to help with lung recruitment without overdistension. So again, it's a fine balance, but the PEEP is very, very important in these patients to help open up their lungs and allow for proper gas exchange. And we talked about oxygen therapy and adjusting that FiO2 properly to target a nice SpO2 that really is on the lower side in the 90s there, but really helps to prevent inflammation and those formation of free radicals long term. So again, permissive hypercapnia is also something that we employ to help prevent BPD. Now, on the flip side, when we look at somebody with severe BPD, again, this is completely different because now we have somebody who most likely has high resistance in their airway and a very low compliance. So that lung is having a hard time distending. So we have to treat these patients differently. Remember, we're not trying to prevent BPD here. These patients have BPD. So now we have to treat them with all that we've got here. So larger tidal volumes are usually needed for these patients, upwards on average of about 10 ml per kg body weight we use, just because we need to overcome all of their issues in terms of low compliance and high resistance in the airway. We like to use a longer inspiratory time here, at least 0.6 seconds, and also a higher target SpO2, because again, these patients tend to have a harder or more difficult time with gas exchange. So rather than being on the extremely lower side in the 90s, we do target or actually appreciate more in the mid 90s here for an O2 saturation. We still allow for permissive hypercapnia because again, it allows for facilitating weaning of mechanical ventilation. And remember here, very important, we like to keep the rate on the slower side in terms of the respiratory rate. If you have somebody who's breathing at a high rate on the ventilator, these patients are not going to empty their lungs effectively, okay? They're going to be retaining a lot of air. So if we have a slower respiratory rate, especially when we have larger tidal volumes in place, we see that these infants have an easier time emptying the air at a lower rate because we have some more time that's allowed for both inspiration and expiration, okay? Keep in mind, of course, we don't want to overdo it with the pressures and over distending these infants' lungs, but of course, you know, we have to do what we have to do in order to allow for the best gas exchange and best clinical picture for these patients. But just understand that that over distension can certainly cause some agitation and also worsen ventilation. And remember too, a lot of these factors are all interdependent. The rate, the tidal volume, the inspiratory, expiratory times, the pressure support, they all come into play together. So once we start to change one thing, one of the other factors are usually affected. So we need to keep an eye on all of these in terms of treating our severe BPD patients. Putting this into picture form here, again, a nice picture out of the Nature Review. You can see, looking here, this is a severe BPD patient, and looking at the best type of ventilator strategy that we should be using. On the left-hand side here, you can see, this is the strategy we should not be using for severe BPD. Look right here, you have this part of the airway with a low compliance and a high resistance. And if you're using low tidal volumes and short inspiratory times, you're not going to have a nice airway, a nice distribution of the gas exchange here. You can see here the adverse effects of using this type of ventilator strategy in severe BPD will cause higher PCO2 levels, the need for higher FiO2, progressive atelectasis, and that regional overdistension. On the other hand, when we employ the strategy I just talked about on the previous slide, you can see here that that higher tidal volume, the longer inspiratory time, and that slower rate allow for that improved gas distribution, lower PCO2, and lower FiO2 levels. So again, take this into consideration when treating your severe BPD patients. So corticosteroids are always a big debate here. We already talked about antenatal steroid therapy, but let's talk about the use of systemic and inhaled corticosteroids, which have really been studied extensively, particularly dexamethasone. We know this particular glucocorticoid has the potential to increase surfactant synthesis, decrease pulmonary edema, and also inhibit prostaglandins and leukotrienes. So this all sounds great, right? This is what we would like in an infant, especially with severe disease. However, there have been some studies that have come out in the past looking at the use of systemic corticosteroids in this type of population. And a group such as Papile and his associates showed that early use of corticosteroids, especially in the first 2 weeks, may actually worsen neurologic outcomes and actually not prevent BPD. So again, you know, you're trying to help boost maybe perhaps an infant surfactant synthesis, but at the same time, you certainly do not want to cause any kind of worsening neurologic outcome. Now, On the other hand, there have been some smaller randomized controlled trials using even shorter courses of dexamethasone. And these randomized trials have been published, particularly in pediatrics, over 10 years ago, and have showed that when we deliver these steroids at a lower initial and total dosage than used previously, there is in fact a reduction in the duration of ventilation of these infants. And in fact, using these lower doses and for a shorter time period does not actually affect long-term neurodevelopmental impairment. So from a clinical standpoint, if we are using, and usually most hospitals have some kind of protocol in place in terms of using steroids, or at least tapering these steroids appropriately. If we use them appropriately, I feel like for somebody with severe disease, from a clinical standpoint, sometimes it ends up being very beneficial to have these patients on systemic corticosteroids. Now, the big talk of late has been inhaled corticosteroids. There have been some trials out looking at inhaled budesonide, really to help prevent the systemic effects that we see with dexamethasone or methylprednisolone, for instance. But this particular trial, called the Neurosis trial, using inhaled budesonide, showed a reduced rate of BPD, but a follow-up study showed no improvement in the rate of death or disability. And in fact, with this particular study, unfortunately, there was an increased risk of mortality compared with placebo. Now, there have been some other trials looking at inhaled budesonide that have actually looked very promising. I mean, we see here, even though we do have some increased risk factors with using it, the reduced rate of BPD is in fact, I think, again, from a clinical standpoint, if you have an infant with an obvious obstructive pattern and may benefit, has wheezing on exam, for instance, and may potentially benefit from the use of inhaled budesonide, then, again, you have to weigh those benefits versus risk. But know that, again, there's always some kind of risk factor in using certain medications. A randomized controlled trial of over 200 infants that weighed less than 1,500 grams, so very low birth weight, was looked at and treated with a combination of budesonide and surfactant versus just surfactant alone. And this combination was administered intratracheally, and the rates of death, or BPD, were 66% with surfactant alone and only 42% with the combination therapy. So again, this is something that's also been in the works, combining the budesonide and surfactant therapy and looking at the rates of BPD. And this particular study actually seemed to be very promising in terms of reducing that rate even further than just using surfactant alone. And in fact, with using the combination therapy of budesonide and surfactant, there were no significant differences in the rates of neurodevelopmental impairment, but there still is some work that needs to be done in terms of the optimal dose, and larger trials are certainly needed. We must touch upon diuretics briefly. Lasix is usually the treatment of choice in these infants early on, or even throughout their course in the NICU, for instance, or even after they leave the hospital. We tend to use thiazides or aldosterone inhibitors or a combination. But fluid overload tends to be something that we must consider in these patients, especially if they appear to have clinical signs on exam. But we know that the diuretics help to improve their pulmonary status and function, and also help to decrease that pulmonary vascular resistance. But again, like with every drug, especially diuretics like Lasix, they do have their adverse effects, especially in the way of electrolyte abnormalities that need to be followed with these patients who tend to be on these treatments long term. But again, something that we always take into account when treating these patients. Bronchodilators are very important. Both albuterol and ipratropium bromide, they really do help in our infants who have wheezing, have an obstructive pattern, to really help improve their lung compliance in the short or acute setting. And very few adverse effects have been noted with these. And when they're combined, there have been some studies that have even found them to be even more effective. Methylxanthines, or something like caffeine, is typically used in those infants to prevent apnea of prematurity. So really to help increase respiratory drive, decrease their apnea, and improve diaphragmatic contractility. And it's also been shown that methylxanthines like caffeine may help to decrease pulmonary vascular resistance and increase that lung compliance in BPD, which is obviously very important. Also, it has been found in some studies that things like caffeine, using caffeine in this setting, help to directly cause smooth muscle to relax and also have some diuretic effects. So a lot of positives go into account with all of these drugs in helping to bronchodilate these patients, and again, helping to improve their lung function, both in the acute setting and also long-term. They've also looked at some researchers the use of vasodilators like inhaled nitric oxide, which we know to be a short-acting gas. The results are mixed here. They've used varying entry criteria, and there have been varying outcomes in preterm infants. So the benefit of using this really remains unclear, but we know that inhaled nitric oxide itself does have some anti-inflammatory components at very low concentrations. So something to certainly consider long-term as well. And there are studies underway that are still looking at that. Last poll here, we're getting to the end, and I really want to spend some time, maybe in the last couple minutes, talking about some emerging therapies here. But let's look at our last question here. Approximately what percentage of patients with bronchopulmonary dysplasia can be expected to be rehospitalized within the first 2 years of life? And you see the choices displayed there. So first 2 years of life, what percentage can we expect to be rehospitalized? Okay, so the correct answer is 50%. So close, one vote off from, or at least a tie anyway. But we'll talk here now about some long-term management. In the preterm infants that have severe BPD that go on to develop a very severe picture, there are related comorbidities that are taken into account, especially after discharge. Unfortunately, with those patients who require mechanical ventilation and have failed extubations, sometimes these patients require, or usually, if we're talking about this kind of a picture, they usually require tracheostomy and typically high inspired O2 levels that we end up having to wean in the outpatient setting as tolerated. And again, these patients have multiple respiratory medications that they must continue to be on long-term anyways, until they at least grow and we can see how they do improve long-term from a clinical standpoint. The most severe subgroup of BPD, remember I talked about all these different definitions early on, but that type 2 severe BPD, or those patients that are on mechanical ventilation long-term, they have the highest risk of late mortality, unfortunately, with poor cardiopulmonary outcomes. And this is all further complicated by many other contributors to underlying pathophysiology of the lung. And again, there's work that needs to continue to be done to really define these distinct respiratory phenotypes of these patients with BPD, because they're not all the same. They really do vary. And by defining some of these different distinct phenotypes, it will help long-term with helping to determine prognosis of these patients. So again, we talked 50% of these patients with BPD are usually rehospitalized on average within the first 2 years of life. We see this in our center because of these many different respiratory viruses out there, especially ones like RSV and flu. They tend to provoke these pulmonary exacerbations, causing these patients to be rehospitalized. Long term, we worry about these patients having a higher risk of asthma-like symptoms during preschool and school age years. And there have been some longitudinal studies that show this obstructive pattern continuing even into the adult years, whereby they follow these patients with pulmonary function testing and have shown that these patients, even as adults, continue to have an obstructive-like pattern that needs to be treated. So last couple minutes here, and then we'll open it up to question and answers if there are any. So there are many, many promising emerging treatments that I see being employed hopefully within the next decade or so. We'll start with here, these multipotent mesenchymal stromal cells, or MSCs. These are known to be a heterogeneous progenitor population of cells that have been found within the lung and have been found in research to help with formation of that alveolar microvasculature, help with repair and regeneration of the lung, and also help to maintain that lung tissue. So there's very, very promising preclinical data that's already out there in both human and animal models. And the thought is that potentially these MSCs, or mesenchymal stromal cells, are potentially disturbed in BPD, which is maybe provoking the pathogenesis of this disease to happen in the first place. So researchers have been looking at cell-based therapies using MSCs to be instilled intratracheally, potentially, to help really promote that lung development and really help to prevent that lung development inhibition of these patients with who may go on to develop BPD early on. The only issue is researchers have found that there are some issues maybe with isolating these MSCs appropriately. But what they have found, interestingly, is that these MSCs work usually via a paracrine mode of action with exosomes. So the MSCs themselves actually secrete these vesicles known as exosomes that actually contain nucleic acids, a lot of good stuff, a cocktail of nucleic acids, different proteins that may go on to help form that alveolar microvasculature in a very promising manner long-term. So again, a lot of work going into this and looking at this, and it does seem to be very, very promising. In fact, these MSCs have also been shown via this paracrine mode of action to go on to affect which pathway alveolar macrophages take. So we know alveolar macrophages are very important in the immune defense of the lung. They either usually go towards an M1 phenotype or an M2 phenotype. The M1 phenotype is usually pro-inflammatory, whereas the M2 really promotes healing and tissue regeneration, et cetera. And it's been shown that the cell-based therapy actually helps promote these macrophages towards that M2 or wound healing phenotype, which is very promising looking forward. The lung microbiome also appears to be a very hot area here within BPD. It was thought years ago that the lung was sterile, that we did not have any bacteria present there, but in fact, it has been shown that both the upper and lower airways are colonized even in utero. The composition varies, but in newborn infants, it's been shown that they predominantly have Acinetobacter, and this changes and stabilizes within that first month of life per the research that's out there. But the thought is that by having an imbalanced microbiome or dysbiosis, this may in fact impact inflammatory or tissue repair to oxygen exposure. So how do we go about preventing this or boosting or promoting a healthy lung microbiome? Well, there's been talk with using azithromycin, which I'll talk about on the next slide why, but this has actually been shown, this macrolide antibiotic, to help reduce the risk of BPD in preterm infants, especially those whose parents or moms have been colonized with ureaplasma species, in particular those moms who have been diagnosed with chorioamnionitis and those babies who have gone on to have BPD. There are some studies looking at using azithromycin, and it actually looks, again, to be a very hopeful treatment moving forward. The reason why the macrolide antibiotic seems to be promising is that it actually promotes the formation of this D-tryptophan, which is a metabolite of microbes that ends up being a potent probiotic that could actually help eliminate allergic airway inflammation. And it's been tested in a mouse model of allergic airway disease. So the benefit long-term of pre or probiotics in promoting a healthy growth and lung microbiome, again, it's still out there and researchers are still doing a lot of work in this area. But in particular, they are looking at this particular catabolite or metabolite, D-tryptophan, and also lactobacilli itself. This has been actually supported by studies in mice with a positive correlation between microbial abundance and lung development. So very interesting to think about as we move forward. And finally, some other emerging treatments we talked about throughout this presentation, the increased inflammatory state of BPD. With the advent with a lot of these different monoclonal antibodies, there has been some hope with even considering the use of some of these anti-inflammatory agents in patients with BPD. So things like interleukin-1 receptor antagonists, which is actually used in rheumatoid arthritis. It's been shown in some studies to prevent the development of experimental BPD at low doses in a neonatal rodent model, which was exposed to a hyperoxic environment and also perinatal inflammation. And preterm infants themselves with BPD have been found to have elevated levels of this particular interleukin in their tracheal aspirates. So the use of this particular antagonist may be a beneficial agent in the future. Looking at glyburide, something that is used to treat diabetics. This particular drug, one of the other mechanisms is that it actually prevents the formation of a NOD-like receptor family or something that is actually associated with inflammasomes or the development of inflammation in general. So this drug is also being looked at in order to see if this can help ameliorate BPD development. And then we've talked about inhaled budesonide, but there are some studies even looking at the use of this in helping to decrease gene expression of certain pro-inflammatory chemokines, cytokines in the whole lung. Some other promising options out there include some other treatments potentially to decrease reactive oxygen species or ROS. Remember, these infants are exposed to elevated levels of oxygen. So by protecting and restoring their normal alveolar and microvascular development, some of these treatments to help reduce these free radicals may help in the long term with these patients. One of the few antioxidants that has been trialed is vitamin A therapy, which actually has shown to have some benefit in human BPD patients. But again, more targeted approaches are certainly needed. And then again, in terms of a genetic standpoint here, there are many developmental molecular pathways that are downregulated, unfortunately, in BPD. So there is some work out there looking at microRNAs and how they may go on to target transcription of multiple signaling pathways at once. So you can see here, just based on this presentation, there's been a lot going on over the last more than 50 years. We've improved BPD definitions. Current medical management has certainly seen a huge improvement. We talked about the importance of ventilatory strategies, both for prevention and also to treat severe BPD. And we just saw on the last few slides how promising the future does look for BPD. So with that being said, we will open it up to some questions right now, but I did want to just make a comment and just mention again that this webinar was sponsored today by MDForLives.com. It's a premier healthcare market research firm. Medical doctors can register for free and become a part of this global community, which offers the opportunity to take up quizzes, participate in surveys, etc., and earn attractive honoraria. So certainly sign up today on their website. We saw the video at the beginning. And now I'll take any kind of questions right now. Let me see if I open up my... From Jessica. I mentioned Lasix, but what about hydrochlorothiazide and spironolactone combo? Yes, we do definitely use this, especially as we transition these patients from Lasix. This is usually our go-to, something like diaryl chlorothiazide or combination of the both. We do definitely support the use of that, especially in the outpatient setting. So for sure, that is something that we definitely use on a frequent basis. Anything else? Okay, well, again, thank you very much for listening. Thank you, MDForLives again. And I again look forward to seeing you all soon.